Hello and welcome. Today we have Dr. Dave Kann, co-PI of the Gene Health Project and Medical Director for Precision Medicine. He is presenting the introduction of the WellSpan Gene Health Project. Dr. Kann, all yours.
Thank you very much, and sorry for any technical problems. This is a 4-year project. We are already committed to it. It's a project where we plan to collect whole exome sequences on 100,000 patients, and it's a big research project. You can imagine with each of us having about 23,000 coding genes and 100,000 participants, it will be an enormous amount of data from which we'll be able to do an enormous amount of research. In addition to that, there are by now 10, soon to be 20 other institutions like us across the country that will be joining, and their data will also be combined with ours after all of it is de-identified. And it will take people that really understand big data to make sense of it and make what I expect to be startling research discoveries. So the way it works is volunteers for the study submit a sample of blood right now, maybe in the future saliva, after informed consent, and that's done electronically. And the benefit to the volunteers is that they learn about heritable traits like whether or not they like sweets, whether they respond well to caffeine, where their family background is from, and they seem to like that. And the other benefit is they learn about CDC Tier 1 diseases, which currently are familial hypercholesterolemia and hereditary breast and ovarian cancer and Lynch syndrome. And I'll talk a little bit about those in a little while. That's the benefit to the patient. They learn about that. They also learn about their heritable traits. We get an enormous amount of data as a result and hope to do some really wonderful research with it. So that's the introduction. That's what I'm going to be talking about. This is really the only slide that I ever read because all of it is important. So what are we doing here? We want to improve the overall health in our communities. We want to provide our patients and their physicians with meaningful, actionable insights from their genomic data. We want to lay the foundation for future research. We want to be recognized as a leader in personalized care and precision medicine. We want to strengthen our relationships with academic and research partners. We want to recruit new and forward-looking talent to WellSpan. What I didn't mention is that after the exomes are sequenced, the data is all stored digitally so that if in the future a clinician wishes to look into a genetic question, that clinician can sit down at Epic and ask a question: does this patient carry such and such a gene? And their motto is sequence once, query often. And as of now, they have the ability, for instance, for us to sit down on people who have participated and do pharmacogenomic testing, which means we can look and see if a person is able to metabolize different medications well or not so well, et cetera, et cetera. As I mentioned, there are 10 places across the country. They're courting another 8 or 10. There was just a meeting in San Diego, and they talked about who they're courting. And one of the things that was said is that if they're able to get all the people that are expressing interest, it may well be the single largest biobank in the world. So we want to compile a large set. People have to be 18 years of age or older. They can't have had a bone marrow transplant. We want to get 100,000 patients. I mentioned the 3 CDC Tier 1 conditions, but we are expecting there to be more CDC Tier 1 conditions in the not too distant future, most likely having to do with genetic reasons for sudden death. 1 in 75 people is affected with this, but yet 90% go undiagnosed. And the CDC has labeled them tier 1 because they have shown that screening improves outcome. So familial hypercholesterolemia, there are 4 genes that we look at. There's the LDL receptor gene, the ApoB gene, PCSK9, and the LDL RAP gene. Hereditary breast and ovarian cancer has 2 genes, and Lynch syndrome, which is familial non-polyposis colon cancer and other cancers, has 5 different genes, and each of those variants has a slightly different pathway that needs to be followed if a patient is found to have one of those variants. So let's say, for instance, one of you folks submits a sample and end up having an MLH1 variant. Well, I end up reviewing, I write all the orders for all the blood work, and therefore I review all the findings. If there are any positive findings, I call the patient and I explain what's going on. I offer them an appointment with a genetic counselor, and I offer them an appointment at our high-risk clinics. The genetic counseling is free. Any care that's delivered subsequent to that is not, and billed by insurance the way any other healthcare is billed. So the flow is pretty easy. The order is placed by the electronic health record. It's sent up, the sample is sent to Helix. The patient receives the traits and the CDC results, and then positive findings go to the genetic counselors. And it's an option. It's not something they have to do. And if they want, they can engage in one of our specialty clinics for these things. The genomic data is stored for future use, and I expect that will be a great benefit over time that will enable us to take much, much better care of our patients by understanding the details of their genetic digitally stored data. Possible results, I told you. If nothing is found, the volunteers are happy to have information about their traits. If there is a variant found, then the genetic counselor and the specialty clinic is offered. We are not asking any providers to recruit patients. Recruiting will be done by marketing in a variety of ways. The closest we'll get to asking providers to engage with patients is to hand them a pamphlet and say, this is a really great opportunity for you. Please look into it. And if the patient says, tell me about it, the answer is, it's all in the brochure. I need you to look at that because there's a website that explains every single thing. And that is the involvement of the providers. Patients consent to provide a sample, have their genomic data stored, receive the results, and some questions always come up about whether or not people can withdraw. And the answer is they certainly can withdraw, but just like a CBC or a metabolic profile, they can't have their CDC tier 1 results removed from the record. And when I get to one of the later slides with typical questions, it'll become clear why that's an issue. Patient experience I've gone through. The volunteers, I should call them, not patients, have the option to create a Helix portal, and the Helix website has all kinds of information about their traits, about their ancestry, and about the CDC 1-tier conditions. They don't have to set up a portal, but it's very easy, and the folks I've spoken with all have enjoyed doing that. So what are the frequently asked questions? One of the most common questions is, what about insurance? If I'm found to have a CDC1 variant, am I going to be able to get insurance? The answer to that is that there was a law passed a while ago called the Genetic Information Non-Discrimination Act, and it's illegal to deny people insurance, but I believe it has to be a company with more than 15 employees. But it's illegal to deny them health insurance based on genetic findings. However, and it's important to make it clear, and we have made it clear, that they can be denied life insurance or long-term care insurance. So when I talk to my patients, I always tell them that they have to weigh the benefits of finding out about these diseases that have the potential to really hurt them versus the likelihood of, at some point in the future, maybe not getting long-term care insurance. I talked about the medical record. And below, at the very bottom of this slide, and there'll be pamphlets, you don't have to write this down. Becca Eberly is the clinical research nurse. And if anybody calls that number, we now have 3 or 4 people that are answering phones, and they can get their questions answered that way. I just wanted to say a word about where we are in time and space. As of this morning, we have sent, we have a total outreach of over 100,000 patients. We've enrolled 2,450, and we've resulted 556. We've drawn a total number of 1,514 samples as of this morning. It's probably more by now. So I feel that we are well on our way. Our goal is to do 100,000 in 4 years. And I think I'll stop there, answer questions, and then if there are no questions, talk maybe a little bit about research opportunities, but I'm hoping there are a lot of questions.
I have a question about how you analyze and interpret the data. So based on what I'm understanding from your presentation, you're going after germline variants rather than somatic.
Right.
And if that's the case, our patients are enriched with specific type of disease, i.e. solid organ malignancy. So how do you differentiate between the somatic and germline variants among this enriched group of patients who may have circulating tumor DNA that may confound and contaminate your data?
I have not heard anyone say that the data will be contaminated by patients that have cancers. But I have heard Helix talk about wanting to do somatic testing in the not distant future.